Hello friends, welcome back to my YouTube channel, that is ENT Chronicle, and topic of discussion for today is the granulomatous diseases of the nose. So how do you define granulomatous disease? So any chronic infection leads to the formation of granulomas. So basically, granulomas are manifestation of long-term infection, and this infectious pathology can be either bacterial, fungal, or of some unspecified etiology. All right. So how are these granulomatous diseases of the nose classified? They are classified into bacterial. In bacterial, we have rhinoscleroma, syphilis, TB, lupus, and leprosy. All these bacterial diseases may lead to formation of granuloma in the nose. Next, we have certain fungal diseases which include rhinosporidiosis, aspergillosis, mucormycosis, candidiasis, histoplasmosis, and plastomycosis. And granulomatous diseases of unspecified origin, there are three which include Wegener's granulomatosis, T-cell lymphoma, and sarcoidosis. All right, there is something also known as the non-healing granulomas of nose. So, details of these non-healing granulomas are not important. You just have to remember the names. The non-healing granulomas include Stewart's granuloma, Wegener's granuloma, eosinophilic granuloma, giant cell granuloma, and cholesterol granuloma. So in this video, we will limit our discussion to all these bacterial granulomatous disease, of which rhinoscleroma is the most important, and in fungal, we will discuss about rhinosporidiosis. Otherwise, I have made a separate video for mucormycosis, and these unspecified granulomatous disease and these fungal disease are much more important in the medicine point of view rather than ENT point of view. All right, now let's start with rhinoscleroma. Rhinoscleroma is often referred to as woody nose. Alright, woody nose is the other name of rhinoscleroma. So, going by the definition, of course, it's a chronic granulomatous lesion of the nose which occurs primarily in the nose and the nasopharynx. But it is not limited to nose and nasopharynx. It can affect other sites as well, such as the trachea and larynx as well. Alright, so rhinoscleroma is caused by a gram-negative bacteria known as Klebsiella rhinoscleromatis. Rhinoscleromatis. Alright, so this is the causative organism for rhinoscleroma, that is gram-negative Klebsiella rhinoscleromatis as the name. Alright, now there are three important points that you have to keep in mind. That is, von Hebra was the scientist who first identified rhinoscleroma, alright, this disease, and on his name, rhinoscleroma is also referred to as Hebra nose, alright. Now, von Frisch, the bacteria Klebsiella rhinoscleromatis was discovered by the scientist named as von Frisch. Therefore, Klebsiella rhinoscleromatis is often referred to as the Frisch bacilli. Alright, and histology of rhinoscleroma was devised by Mikulicz. Alright, so remember the name. Mikulicz discovered the histology of rhinoscleroma. Rhinoscleroma itself was discovered by von Hebra, therefore it is known as Hebra nose, and Klebsiella rhinoscleromatis was discovered by von Frisch, therefore it is known as Frisch bacilli. Alright, rhinoscleroma can affect people of any age group, but there is some female preponderance in the cases. Alright, now what is the etiology? First, we have bacterial etiology, that is Klebsiella, and rhinoscleroma is endemic in some parts of India. It is more common in low socioeconomic background, and there are multiple factors for its causation. Alright, so this is the etiology and the causative agent of rhinoscleroma. It can affect persons of any age group. Alright, now let's move towards. Before doing the sites of infection, let us just talk about the clinical features first. Alright, these are more important. So, clinical features of rhinoscleroma are divided into 4 stages. Alright, what are those stages? Let's read about them one by one. First stage is referred to as the catarrhal stage. You have to remember these names by heart. Next stage we have the atrophic stage. Next stage we have the granulomatous stage, and finally we have the stage of cicatrization. Now let's talk about them in detail. So in catarrhal stage we have a foul smelling purulent discharge from the nasal cavity, and this foul smelling purulent discharge is so thick in consistency it is often referred to as the carpenter's glue. All right, remember this terminology. The discharge is referred to as carpenter's glue because it is very thick and purulent in nature. So carpenter's glue discharge occur in catarrhal stage. All right, next we have, after catarrhal stage, the disease intensify to atrophic stage. In atrophic stage, of course, there is atrophy. So there is going to be atrophy of nasal mucosa, mucosal atrophy. There are going to be crustaceans in the nasal cavity. All right, and these crustaceans have been given a specific color, that is the honeycomb color crustaceans. All right, honeycomb color crusting in the nasal cavity. Atrophic stage of rhinoscleroma is almost similar to atrophic rhinitis, and diagnosis of rhinoscleroma at this stage can be made by a test known as the Levin test. All right. Okay. Now next stage we have the granulomatous stage. In this stage there is formation of granulomatous nodules, and every single word describing these nodules are highly important. First of all, the nodules are reddish, they are non-tender, they are irregular in size, which are rubbery. All right. Now, as soon as these reddish painless nodules are touched, they bleed. All right, and this is the stage in which bacteria are most frequently isolated. So bacteria, Klebsiella rhinoscleromatis, are most frequently isolated in which stage? Granulomatous stage. All right, and one thing you have to remember, that these reddish nodules have cartilage like consistency. They are firm, not soft. They have cartilage like consistency. And finally we have something known as the stage of cicatrization. Now cicatrization itself means fibrosis. So there is excessive fibrosis in the nasal cavity, and this is leading to deformities. All right, now the deformities include something known as the tapir nose. We have seen woody nose, we have seen hebra nose. Now we are going to see the tapir nose. What is tapir nose? It is a woody feel on palpation of nose because of excessive fibrosis in the nasal cavity. I have even attached the diagram for you guys. So in this diagram you could see reddish nodules which are painless as stated by the patient. They are irregular in size. These reddish nodules are irregular in size, and on palpation they will bleed and have cartilage like consistency. They have cartilage like consistency. All right, now these two animals, that the nose are similar to these two animals, that is the tapir and hebra animals. Therefore the manifestation of rhinoscleroma in humans is given this name, that is the tapir nose and hebra nose. All right, just remember what is tapir nose. It is a woody feel on palpation of nose. All right, we have discussed about the clinical features. Now let's discuss about the what sites of infection. So rhinoscleroma, as stated in its definition, major point of infection is nose and nasopharynx, but it can also affect other sites. Now let's discuss those sites. First is the nasal cavity. It is the most common site affected by Klebsiella rhinoscleromatis. Now there are further specific sites which are affected in nasal cavity. Those include, most commonly affected is inferior turbinate, then middle turbinate is affected next, and least affected out of all these three is anterior wall of nasal septum. All right, so remember, most out of all these site, nasal cavity is most common site affected, whereas inside nasal cavity inferior turbinates are the most susceptible part of the susceptible part for this infection. All right, other sites include nasopharynx, oropharynx and larynx as well. In larynx, the most common site involved is the subglottic site. All right, Remember, in nasal cavity is the inferior turbinate, whereas in larynx it is the subglottis. Whereas rhinoscleroma might as well occur in trachea and bronchus, although they are very uncommon sites for these infection. Alright, so sites of infection is done. Now let's talk about two important signs. First, we have something known as the Gothic sign, and then we have something known as the V sign found in rhinoscleroma. Alright, what is Gothic sign? Due to excessive fibrosis in the nasal cavity and pharynx, the pharyngeal wall are pulled upwards because of fibrosis. And because of this, the posterior pharyngeal wall now appear as the church top, because the fibrosis pulls up the pharyngeal wall, and this appears like a church top. Therefore, this is referred to as the Gothic sign in rhinoscleroma. Another sign seen in rhinoscleroma is V sign. What does V sign mean? It's a V-shaped palate seen on X-ray in cases of rhinoscleroma. Alright, just remember these two signs. Gothic sign, which is the pharyngeal wall is pulled upwards and resembles the church top, and V sign, we have V-shaped palate seen on X-ray. Now let's see how will we diagnose rhinoscleroma. Diagnosis is exclusively done on the basis of biopsy, and in biopsy we see the infiltration of mucosa by first plasma cells. These can be easily identified with placement of nucleus eccentrically. They have eccentric nucleus. Alright. Infiltration of some mucosa by plasma cells, lymphocyte, eosinophil, and these two, that is the Mikulicz cells and Russell bodies, are absolutely specific and diagnostic of rhinoscleroma. What are Mikulicz cells? These are large foamy macrophages which have the causative organism in them. Alright. Next, we have something known as the Russell bodies. Russell bodies are eosinophilic inclusion bodies in plasma cell. These Russell bodies are homogeneous in nature. Alright, remember these terms. So what is a specific point we have to see in the biopsy of rhinoscleroma nodules? Presence of Mikulicz cells and Russell bodies. Mikulicz cells are nothing but foamy macrophages. Now let's see the biopsy. In this diagram, there is metaplasia of the respiratory epithelium due to chronic infection. That is not very specific. Specific, we have Mikulicz cells. Alright. In this diagram, you guys could easily appreciate the presence of large foamy cells, and inside these foamy cells we are able to see certain organisms which are nothing but Klebsiella rhinoscleromatis. Alright, now these pink lines, these are Klebsiella rhinoscleromatis. Along with Mikulicz cells, we also have plasma cells. We also have eosinophils. Alright, presence of eosinophils, plasma cells, and lymphocytes. So this is the biopsy of rhinoscleroma nodule. Alright, let's move ahead. Now, how are we going to treat rhinoscleroma? Alright, so treatment is, first of all, we have medical treatment. Medical treatment, we give both the drugs. That is, we give streptomycin and tetracycline in the doses of 1 gram per day and 2 gram per day respectively. Alright, what we give in medical treatment? Streptomycin as well as tetracycline, 1 gram per day and 2 gram per day respectively. And this drug combination has to be given for at least a period of 4 to 6 weeks. Alright, this has to be given for at least period of 4 to 6 weeks. Now there is something known as the Kaliasha regime. Now Kaliasha regime is made up of 3 chemicals, that is carbolic acid, glacial acetic acid, and glycerin. This can be applied to the nasal cavity and has some positive results in effective treatment of the rhinoscleroma nodules. Now, if the nodules are pretty large and extensive, we might as well prefer surgical options, which include removal of those nodules with the help of electrocautery lasers. Now, these two can be employed to remove the nodules, whereas the patient would be advised to undergo plastic reconstruction only and only if there are 3 consecutive biopsies which occur negative for Klebsiella rhinoscleromatis or Mikulicz cells or Russell bodies. Alright, plastic reconstruction can only be done if 3 consecutive biopsies are recorded to be negative. Alright, so this was all about treatment of rhinoscleroma. Now let's move to another granulomatous disease, which is syphilis. So, as we all know, the causative organism of syphilis is Treponema pallidum, and most common mode of transmission of syphilis, sexual transmission. Now let's quickly see the classification of syphilis. So syphilis can be acquired in nature and it can be congenital in nature as well. Acquired can be further of primary type, secondary type and tertiary type, and congenital is of two type: early form, which is seen in newborns, and late form, which is seen around puberty. Alright, now let's discuss the signs and symptoms of these individual stages. Now, the primary acquired syphilis, first of all, it is a very rare thing, and if it is presented in a person, it manifests as primary chancre of the vestibule or of external nose. In this diagram, you guys could see the primary chancre of external nose right here. So this is the primary acquired syphilis, which is rather rare in nature. Next, we have secondary acquired syphilis, which is also rarely recognized. It has the combination of the following sign and symptom. First of all, the patient is going to experience simple rhinitis along with crusting and fissuring in the nasal vestibule. All these points are very important in the diagnosis of secondary syphilis. Secondary syphilis is rarely recognized because all these features, that is simple rhinitis, crusting and fissuring, are quite non-specific. They cannot be attributed directly to secondary acquired syphilis. Therefore, it is rarely recognized. Alright, and how we make diagnosis of secondary syphilis along with these. Alright, if the patient complains of mucus patches in the pharynx along with pyrexia and skin rash and general lymphadenitis, then the diagnosis of secondary syphilis can be made. Alright, so mucus patches in the pharynx, pyrexia, skin rash and general lymphadenitis. Now let's talk about the skin rash in secondary acquired syphilis. Now, skin rash in secondary acquired syphilis is symmetrical. Alright, it is symmetrical. It is divided equally on both parts of the body. The color is pink. The color of skin rash is pink. It is coppery or dusky in color, as you guys could appreciate in diagram. In this diagram, it is symmetrically spread all over the body. Now, there is also something known as the snail track ulcer, which are seen in the oral mucosa. As you guys could appreciate that this is looks like a track of snail. So this ulcer in the oral cavity are referred to as snail track ulcer, also specific of secondary acquired syphilis. Now let's move ahead towards the more important one, that is the tertiary acquired syphilis. Alright. In tertiary acquired syphilis, nose is commonly involved and thus it becomes important from the ENT point of view. So tertiary acquired syphilis, first of all, there is going to be gamma formation on the nasal septum. Alright, so there is gamma formation of the nasal septum. Now this is the gamma of the oral cavity, and similar to this we have gamma of the nasal septum as well. Now after formation of gamma, there is going to be destruction of the nasal septum. So there is going to be nasal septal perforation, and after this we will see the perforation in the hard palate. Alright, you guys could appreciate in this diagram there is perforation of the hard palate due to tertiary syphilis, and finally due to destruction of nasal septum, the nasal bridge of the nasal nose will collapse. Alright, and this will lead to the characteristic saddle nose deformity. Alright, so what are the signs and symptoms of tertiary syphilis? We are going to see gummy on nasal septum, and finally the nasal septum will collapse and get destroyed. There is going to be perforation in the hard palate, as you guys could appreciate in this diagram, and finally we are going to see the characteristic saddle nose deformity. Alright, so this was all about the tertiary acquired syphilis. Now let's move towards the congenital syphilis. Now congenital syphilis, I have already told, it is of two types: early form, which starts early after birth, that is first 3 months of life, whereas the late form of congenital syphilis is gets manifested around puberty, and the signs and symptoms of congenital syphilis, its late form, are similar to tertiary acquired syphilis. Alright, So the late form has characteristics similar to the tertiary acquired, whereas early form manifests as snuffles. All right. So now this is a picture of congenital syphilis. This baby is suffering from congenital syphilis. Now, what are snuffles? Due to excessive nasal obstruction in the nasal cavity because of syphilis, the baby tend to lose his breathing ability and thus produces sound, and these sound are typically referred to as snuffles, or also referred to as the syphilitic snuffles. All right. So just remember, early form of syphilis, congenital syphilis specifically, manifests as snuffles, whereas in late form we see something known as the Hutchinson's triad. So just remember, what is the triad made up of? It is made up of three things: HIN. First of all, since it is Hutchinson triad, there is going to be Hutchinson teeth. Now, what are Hutchinson's teeth? These are sharp teeth in children because of syphilis. These referred to as Hutchinson's teeth. H we have completed. With I we have the eye problem referred to as interstitial keratitis. Alright, next in Hutchinson triad we have interstitial keratitis, and with N we have nerve 8 deafness. Alright, Hutchinson triad is completed with presence of Hutchinson teeth, nerve 8 deafness, and interstitial keratitis. Just remember, in the mnemonic is present in the triad only, that is HIN. So this was the Hutchinson's triad. Alright, now let's move. How will we diagnose syphilis? So, syphilis diagnosed with a famous test that is referred to as the Venereal Disease Research Laboratory test, and finally we might as well do biopsy of the tissue and still find out the cause of the sign and symptom. Okay, treatment of syphilis is very easy, and you have to remember all these points by heart. So the drug of choice for syphilis is penicillin. All right, and what is the dosage of penicillin? So we give benzathine penicillin at a dose of 2.4 million units intramuscularly. All right, and this benzathine penicillin has to be given every week for around 3 weeks. So total dose becomes 7.2 million units IM of benzathine penicillin. Alright, so DOC of syphilis is penicillin. Alright, let's move ahead towards the tuberculosis of nose. First of all, tuberculosis of nose is a rare condition, and it is almost always secondary to lung tuberculosis. You have to remember this point. And what are the sites involved in tuberculosis of nose? First, we have the anterior part of nasal septum. Then we have anterior end of the inferior turbinate. Just remember these two sites. They are typically involved in tuberculosis of nose. Now let's talk about the pathology. Now, first there is going to be nodular infiltration in tuberculosis of nose, and now these nodules will ulcerate. All right, now there's going to be ulceration of these nodules. All right, and after this the nasal septum will perforate. So there is perforation in tuberculosis of nose as well. And what part of nasal septum will perforate? In tuberculosis of nose, cartilaginous part of nasal septum is characteristically perforated. All right, now let's see what is the diagnosis. Diagnosis is made on Zn staining or acid-fast bacilli staining, and we might as well do biopsy of the nodules or ulcerative tissue. Next, for treatment, we continue ATT as soon as the patient is diagnosed with tuberculosis. All right, so ATT is the treatment. Now, there is another manifestation of lupus. There is another manifestation of TB referred to as lupus vulgaris. So it is TB only, but the difference is it is cutaneous manifestation of tuberculosis. Also, it is low grade tuberculosis, nothing but tuberculosis. All right. What are the sites involved in lupus vulgaris? First of all, we have inferior turbinate, and it also characteristically involves septum. All right. Now, there is something known as apple jelly nodules. So what we see in lupus vulgaris, you have to remember this term by heart. We see characteristic apple jelly nodules. So this is the example of apple jelly nodules seen in cutaneous TB, that is often referred to as lupus vulgaris. And there is perforation of septum. Just like tuberculosis, there is perforation of nasal septum in lupus vulgaris as well. You guys could see in the vestibule, it presents as chronic vestibulitis, and perforation may occur in the cartilaginous part of nasal septum, just like tuberculosis of nose. And you just have to remember, it is a cutaneous TB, low grade TB, and apple jelly nodules are specific to lupus vulgaris. Now, since it is an cutaneous form, low grade tuberculosis, treatment and diagnosis are just similar to tuberculosis of nose. That is, we can do biopsy, acid 5 bacilli staining, and we do anti-tubercular therapy to the patient. Now let's move towards leprosy. Leprosy is caused by, we all know, is caused by Mycobacterium leprae. All right, it is highly common and infectious disease in the Indian subcontinent. So clinical features of leprosy are divided into early stage, then we have the intermediate stage, and finally we have late stage clinical features. Now, these clinical features are not written, I have not written these features from medicine point of view. I have written only those features which are manifested in the ENT parts. All right, so in early stage there is dry, thickened, pale yellowish. What? We have dry, thickened, pale yellowish nasal mucosa. Alright, so mucosa is dry, thick, and yellowish. And this dryness is due to damage to parasympathetic nerves. That is, supply of Vidian nerve is affected. And parasympathetic supply is the one that leads to increased secretion in the nasal cavity. Since parasympathetic nerves are affected, there is going to be dryness in the nasal mucosa. All right, in the early stage. Next, we have intermediate stage. In intermediate stage, we see a combination of nasal block, that is nasal obstruction. We see nasal discharge, and finally there is bleeding from the nose. All right, so there is combination of nasal block, discharge, and epistaxis in the intermediate stage. And finally, again, in the late stage, we see a triad. Now, this triad in the late stage of leprosy, it consists of saddle nose, that is, the septal perforation has occurred. All right, and septal perforation itself a part of this triad. So first we will see septal perforation. Septal perforation will lead to saddle nose, and the third part of the triangle is, this triad is atrophic rhinitis. So what triad do we see in late stage? We see saddle nose, septal perforation, and atrophic rhinitis. Now the thing that you have to remember by heart is most common, along with as well as the first side involved in leprosy, is the anterior end of turbinates. All right, anterior end of turbinates are the first one to be involved in, most common and first side to be involved are the anterior end of turbinates. And right here, this person shows cross destruction of his nasal cavity because of septal perforation. All right. Now there is something known as stages of lepromatous rhinitis. So rhinitis, inflammation of nasal mucosa due to leprosy, is known as lepromatous rhinitis. And this classification, this stage of lepromatous rhinitis was given by Job, Karat, and Karat. So Job, Karat, and Karat give the stages of lepromatous rhinitis. We have 4 stages, 1, 2, 3, and 4, and you remember these stages by using the mnemonic IPDR. All right, IPDR. I, we have invasion. If there is invasion, it is due to inflammatory cells. Next, we have excessive proliferation. Then we have destruction and ulceration, and finally we have resolution and fibrosis, that is cicatrization. All right, so Job, Karat, and Karat says stage 1 is I, then we have PDR, invasion, proliferation, destruction, and resolution. All right, so these were the stages of lepromatous rhinitis. Okay, how are we going to make diagnosis of leprosy? So the sample taken for diagnosis are the scrapings of nasal mucosa, and biopsy can also be done. So what do we see on biopsy? And finally staining the sample by AFB staining, we see something known as the lepra cells. Now lepra cells are typically arranged in structures typically referred to as globi. All right, they are arranged in globi, and these globi have typical appearance of cigarettes in pack. All right, so on lepra cells are seen on AFB staining after sampling, and these lepra cells are present in globules referred to as globi, and these globi have arrangement of bacteria in cigarettes in pack appearance. All right, just like this. These globi have bacteria arranged in cigarettes in pack appearance. All right, now let's move ahead. So how are we going to treat leprosy? Leprosy is treated by combination of dapsone, rifampicin, and clofazimine. Okay, these are the drug regimens for leprosy. The drug regimens and how in what dose these drugs are given are, you have to study these in the medicine section. All right, now let's start with another important section, that is the rhinosporidiosis. It is very important after rhinoscleroma. The next important one is the rhinosporidiosis. Now, I've classified this in the fungal granulomatous disease, but it is caused by an organism referred to as Rhinosporidium sebri. All right, what is the name of the organism? It is Rhinosporidium sebri. This Rhinosporidium sebri does not follow the Koch postulate. That is, it cannot be isolated from the specimen and it cannot be cultured. There is no culture media on which Rhinosporidium sebri is cultured. All right. Earlier, Rhinosporidium sebri was thought to be a fungus. That's why it is still now classified under fungus. But now it has been proven that Rhinosporidium sebri is not a fungus but an aquatic protestant parasite. It is an APP, that is aquatic protestant parasite, which is a member of a larger group referred to as something known as the drip clade. So what is the composition of drip clade? We have Dermocystidium, rosette agent, ichthyophonus, and sorospermum. All right. So this is too much information. First of all, Rhinosporidium sebri, earlier thought to be a fungus, but now it has been proved as aquatic protestant parasite, which is further placed inside a larger member of group referred to as the drip clade. And what is the full form of drip? We have Dermocystidium, rosette agent, ichthyophonus, and sorospermum. All right. And another thing to be remembered is Rhinosporidium sebri, the causative agent of rhinosporidiosis, does not follow Koch's postulate. All right, let's move ahead. So it typically affects persons of age group 20 to 40 years of age. That is, it is more predominant in younger generation. All right. It is more predominant in younger generation. Males are more commonly affected than females. Almost males are affected 4 times more than females. There is male predominance. All right. There is another point to remember is people with blood group O are more susceptible to infection of Rhinosporidium sebri. Right. Now, what is the mode of transmission is very, very important because they will give a characteristic history. The patient of presenting with rhinosporidiosis will give a characteristic history. So, the patient will complain that he bathed in some river water or some lake water or in pond. And the mode of transmission is bathing in infected water because there are spores of Rhinosporidium in the water. All right. There is also transmission by droplet infection by cattle dung dust. All right. The spores are also present in cattle dung dust as well as infected waters. And cutaneous lesions are spread through contaminated fingernails. So what is the mode of transmission? Typical history will be of bathing in infected water only. All right. So, and this occurs due to presence of spores of Rhinosporidium sebri in those waters. All right. You have to remember this point by heart. Let's talk about classification. Rhinosporidium seabri or Rhinosporidiosis can be benign in nature and it can be malignant in nature. Let benign, the most common site is nasal. Then next we have the nasopharyngeal. Then we have mixed, that it is occurring in the nasal, nasopharynx and also oropharynx as well. The least common is bizarre. Bizarre occurs in conjunctiva. Alright, it is the most rare of benign type. Right. Rhinosporidiosis, it is of two type, benign and malignant. Benign, most common site is nasal. Next is nasopharyngeal mixed, and which occurs on conjunctival sac, is the most rare, referred to as bizarre. Alright. Malignant is nothing but generalized rhinosporidiosis. Alright, in the nasal cavity. That is, the growth has not been stopping. It's the rhinosporidiosis nodules are growing continuously. Right. Now, let's talk about the pH. Now, there is something, a small concept, two concept that are pH concept and histamine content of Rhinosporidiosis polyp. Right. So, the concept is, in normal people which are not affected by rhinosporidiosis or any other nasal ailment, the pH of nose ranges between 5.5 to 6.5. That is slightly acidic. Alright. But in normal people during the humid monsoon season, this pH slightly increases and becomes alkaline. That is 7.2. And it is all physiological. It is all physiological. Alright. So, but if the patient is suffering from rhinosporidiosis, the pH of the nose remains constant throughout the year. Alright, now this remains constant throughout the year. Sorry for the typo. Alright, and because of this constant pH of the nasal cavity, there is high predisposition to secondary infections apart from rhinosporidiosis. Now, you remember this concept by heart. If the question asked why there is predisposition to secondary infection, rhinosporidiosis, just say there is no normal change in pH. That is, the pH does not become alkaline during humid monsoon condition because of rhinosporidiosis. Rather, it stays constant throughout the year, leading to high predisposition to secondary infection. Alright, we have covered the pH part. Now let's cover the histamine content. Alright, so just remember, the histamine content of rhinosporidiosis nodule is very high as compared to a benign nasal polyp. Alright, and because of this extra histamine content, there is excessive favoring of growth of tissues and the blood vessels supplying the nasal polyp. That is, in the case of rhinosporidiosis, this extra histamine favors growth of tissue and there is excessive dilatation of vessels. That is, blood supply to rhinosporidiosis polyp does not stop because of excessive histamine. Alright, now let's talk about life cycle. Life cycle is not very important. You just have to remember, life cycle is composed of 3 stages. First, we have the trophic stage, formation of trophocyte. Then we have development of sporangium, that is from intermediate sporangia to formation of sporangium. And finally we have stage 3, that is spores are produced, that is liberation of spores and formation of endospores. Alright, so life cycle is, endospores are produced in the environment. They are of size 6 to 8 micrometer and their outer wall is formed of chitin. Now this endospore rapidly multiplies within to form young endospores. Alright, now these young endospores lead to formation of trophocyte having further smaller endospores in it. Alright, now they lead to formation of even thick wall, intermediate sporangia, and finally intermediate sporangia changes into the sporangium. Now endospore had one wall of chitin, whereas sporangium has 2 wall, outer wall of chitin only, and it also develops an inner wall of cellulose. Alright, how many endospores are present in a sporangium? There are around 12,000 to 16,000 endospores in one sporangium, and they are all liberated in water, in cow dung, and again the cycle continues. And now, how does a person gets infected? If these endospores are present in a water body and a person takes a bath in it, These endospores are collected in the nasal cavity and further leads to rhinosporidiosis. Alright, now let's move ahead. Now, what are the signs and symptoms? Signs and symptoms of rhinosporidiosis are very, very important. Alright, symptoms include frank epistaxis. Alright, because I have already talked why there is excessive blood supply to the rhinosporidiosis polyp because of excessive histamine content, and because of this excessive histamine content there is frank epistaxis. Alright, blood doesn't stop coming from the nasal cavity. Next, we have nasal obstruction because of presence of rhinosporidiosis polyp. Then we have nasal discharge, and finally the patient also presents with excessive sneezing. Alright, just remember frank epistaxis is the most important one. Now let's talk about signs. So signs is the polyp is pedunculated in nature. It is pedunculated nasal mass. Alright. The surface of this pedunculated nasal mass is studded with yellow white spots, which are nothing but spores, just like a strawberry. You guys could see. So this is the pedunculated nasal polyp, right? And onto which white yellowish spores are dispersed, giving typically a presentation known as strawberry appearance. And finally, if it touch this polyp, it bleeds on touch. So what are the signs? Signs is, first of all, there is pedunculated nasal mass. This pedunculated nasal mass is studded with yellow white spots, which are nothing but spores of rhinosporidiosis. And as soon as we do physical examination of this nasal mass, it bleeds on touch. Alright, signs are very important. Just remember strawberry appearance of these polyp, rhinosporidiosis polyp. Okay, now let's talk about diagnosis and treatment. Diagnosis of rhinosporidiosis is made by biopsy of the lesion. We do biopsy. Alright, and what stain do we use on this biopsy? Remember, the best stain used to make out rhinosporidiosis is Hatchcase McNan stain. Just remember the name, no need to go into details. The stain used in biopsy of rhinosporidiosis is Hatchcase McNan's stains, which is the best stain for rhinosporidiosis. Treatment modalities include both medical. Okay, now we have talked about biopsy. Let's see what do we get on biopsy of rhinosporidiosis. Since I have talked, there is formation of sporangium. Alright, so these are all sporangia. And in each sporangia, how many endospores were there? There were around 12,000 to 16,000 endospores. Alright, so these are 12,000 to 16,000 endospores. And this is the liberation of endospores into the outside environment. So this is the histology or biopsy of the rhinosporidiosis polyp, composed of various sporangias, along with there are also a liberation of endospores from these sporangias. Alright, now let's talk about treatment. Treatment modality include both medical as well as surgical intervention. Okay, medically, dapsone has been tried with some success. So the patient is given dapsone. How does dapsone works in rhinosporidiosis? It inhibits formation of folic acid. Thus, the Rhinosporidium seabreed cannot lead to formation of its sporangium. Although few ENT specialists make out that dapsone is controversial for the use in rhinosporidiosis, because they say, since the wall of endospores, spores and sporangium is made up of chitin, how does dapsone penetrate this chitin? So they say, although some say that dapsone has been successfully treating rhinosporidiosis, the others say, how can dapsone cross the chitinous wall of sporangium of rhinosporidiosis? Right. So if somebody asks why is dapsone controversial, just say there has been few speculations of how does dapsone crosses the chitinous wall. Now, surgery is rather more important. So simply what we do is we do complete excision of rhinosporidiosis polyp with, what do we use? We use the diathermy knife along with cauterization of base. Just remember these 3 points. What we do in surgery, we do complete excision of the polyp with diathermy knife along with cauterization of base. And now, one thing to remember is there is high chances of recurrence in cases of rhinosporidiosis, and because it happens because some part may be left in the submucosal plane. Rhinosporidiosis cannot be completely removed because some part of rhinosporidiosis gets submerged in the submucosal plane. Alright, even after cauterization, there is high chances of recurrence. Alright, so this was the reasons of recurrence. So guys, we have talked about the granulomatous disease, rhinoscleroma and rhinosporidiosis, the more important one. If you like this video, please like this video, share my channel and subscribe to it. Thank you.